the proceedings. So just a little bit of background. I'm from Southampton, which is a little tiny boring city on the south coast of the UK. So there's a map and a pin roughly in the middle of the channel, but the hospital's not there, and I'm a part of the Faculty of Medicine. And I do a lot of things. So most of my time is actually being an Associate Dean for International, so roaming around the planet, talking to lots of different organizations about education and research. But my own research is predominantly looking at digital solutions, both in the delivery of healthcare, but also in research. So I worry about a lot of things, but this is really me giving you some background to how Edge appeared. It's not something that just appeared overnight. It's taken 22 years for us to develop this platform. And it's on the back of basically the United Kingdom's aspiration to have a highly integrated clinical research environment through the NIHR. And again, that didn't happen overnight. And I'm not saying it's the best model in the world, because it's not. So we've made a lot of mistakes along the way. But I just wanted to give you a bit of a history as to where Edge came from. So some of you may be aware of the UK research environment and the UK research networks. And it started off in 2000. There was a review undertaken by the government asking why we were losing clinical trials, particularly cancer clinical trials, to being recruited overseas. So why we're seeing a drop in recruitment into clinical trials in cancer. And to try and address that problem in classic UK government style, rather than solve the problem, they generated a new organization to try and find the answer. So typical UK government. So the first part was we formed a cancer research network. But overall, the NIHR clinical research networks have developed over the last 20 years into us being able to have this much more a balanced portfolio of research. So it was basically to identify what research we were running, where it was running, and was it representative of all of our patients that we're trying to look after, rather than it all being focused in one place. And nobody really knew the answer. So this is a screenshot of currently roughly what the clinical research portfolio looks like across the country. And you'll notice cancer is the biggest one, and that's predominantly because it receives the most funding. So that's reasonably why there's more funding in cancer. So to start where Edge started in a cancer network, I was one of 32 cancer research networks, so a region of people with a number of hospitals, and we were asked to be one of the first of the 9 networks to be set up. So you can see the structure of all the networks across the country, and as I said earlier, I'm in this spot here. And as one of the first networks, we were asked really to sort of think about how we could improve our research and how we could coordinate it better amongst all these different stakeholders. And so it was about establishing sort of a service network that sat on top of the delivery network, so that the trials sit on top of where the actual research is happening, that we would invest in clinical leadership training, loads of capacity building, and we would try and improve the number of trials we were running and speed the process up. So the question basically I was asked was, can I answer these 3 very simple questions? How many trials in the region do we have? How many patients do we recruit? And how do we increase and monitor both of these questions? So that sounds pretty simple. Yeah, just count some trials, I thought naively. And so when I started looking at the problem, I went into the hospital, into our research department, and said, can you tell me how many trials we're running in cancer? And they said, there's some big filing cabinets over there, and you can start counting some brown envelopes, and you can tot it all up and answer whatever question you want to answer. I mean, at that time as well, if I walked into the department and said, I've done a trial, I'd hand over my protocol for getting it approved by the hospital, and then about 160, 180, 230 days later, someone would say, you can go and recruit a patient. So very long time for setup. So these were some of the big challenges we need to, and the information was all over the shop. It was all on paper, basically. Everything was on paper. So this is the way I describe what the world looked like then. So this is obviously an upside down triangle. And at the top, you've got the Treasury, so the government, our Parliament MP questions, our Department of Health, and the pharmaceutical companies talking about, you know, a lack of £32 billion worth of investment into clinical research activity. They created the National Cancer Research Network, which then 32 networks sat underneath. So one of them was SIA7, which was my network. And then under the network were all these hospitals. And at the bottom of the triangle is where I fondly written here, the weirdos and the clinical researchers live. And we were very reliant on using nurses to help us run our trials and get things sorted out. So no systems ultimately where we needed to collect or capture data. So we turned the system up the other way around, and we said if we put in a system that would actually help the clinical researchers and the nursing staff and the pharmacists and everybody else involved do their job better in a way that was helpful to them, then actually the reporting requirements that were needed for everything above would just fall out of that system. So it's about, if I asked you to wash my car, you'll probably say no. But if I say, if you wash my car, I'll tax and insure it for you, put petrol in it and let you drive it, you go, well, that's probably a slightly better deal. So it's the same thing with clinical systems. We give people systems that they don't want to use, are difficult to use, complicated to use. It just becomes a burden and nobody is likely to interact with it. So, yep, we've kind of sort of restructured everything into this new pathway. And then, like I said, this process can actually be applied across different networks that we've set up and run in various other places as well. So it could be about patient-centered care, hospital care, communities, networks, all the same principles apply. Doesn't matter whether it's clinical trials or anything else. It's got to be sort of set up in the right way. So our simplest form was, we said, let's have a database which contains information about the research projects. And let's just imagine we have 2 hospital sites in our network. And what do the doctors and the nurses and the patients need? And the answer predominantly was documentation. So every day I'd watch research nurses go off to clinic with a whole load of, you know, paper, files, folders, printouts of things, and sit in clinic and sort of do stuff. But then if the doctor said, oh, I've got a patient here I want to recruit for a study, and they didn't have the paperwork, some poor person had to run all the way across the hospital to go and find a folder with the right piece of paper in and bring it all the way back to clinic. So it wasn't very helpful. So we wanted to give them something so they could access the information. And so that we found was, first of all, the nurses said, we're never going to use this in a million years. And then about 6 months later, we checked with them and said, are you still using it? And they said, oh yes, we've managed to train all the doctors now. So they log in and get pieces of paper rather than chasing me. So don't turn it off now, because we've just managed to get rid of a whole load of tasks that we were previously being asked to be done. And the doctors were happy because they said, well, if someone rings up about a patient in the middle of the night and I need to refer to the protocol, I don't need to drive into the hospital to break into the clinical trials office to find the protocol, to find out, I can just get at it online. So it didn't mean they need to come into the hospital. So everyone was pretty happy. But over time, more and more people in the process were saying, what's that thing? Well, how do you know the answer to that? So people started saying, can it help us in our research and development office in terms of approval? Can it help our pharmacy department? Can it help this? Can it help that? And so over time, we mapped out all of these people. So if I was an investigator, again, I would have to go to, you know, pathology, to pharmacy, to the research office, to radiology, all over the shop, saying, can I run this study? And they'd give me a form, and the form would say, can you write the name of the project, what it's called, summary, all that sort of stuff. But just repeating, and all this information kind of gets duplicated all over the shop. So everything was already immediately sort of out of date. So loads of people said, well, why don't we try and harmonize all of this? Because if you think about running a study across multiple sites, you can see the amount of duplication that's going on increases, you know, tenfold. So everything was out of date. This was what was causing a long period of time for getting things to be set up. And so we moved to a single model that looks a bit like this. So sponsors or clinical trials units, or it could be a pharma company, could be anybody, basically starts the project in Edge, and then when it's ready to be opened, sites are invited to connect to that record, and they can see all the information, all the documentation online, and they then augment it with their own local information as necessary. So we've moved to a single source of truth. So at the moment, for instance, in the UK, We manage in the NHS over 150,000 research projects. There are about 35,000 users who use that platform daily across the NHS. And we have implementations here, obviously, that you see, but also in Australia, New Zealand, Ghana, India, Belgium, all over Canada, all over the world. So there's we're sort of managing large numbers of projects and large numbers of patients. In the UK alone, we manage about 8.5 million patients in real time in terms of tracking and monitoring them and seeing where they're sort of, being on the study, enrolled, and all that kind of stuff. So we can aggregate that information, so I can tell you at any time in real time what's going on across a particular project or across the whole of the country. But the biggest thing about the EDGE program, and then I'll leave it here for me to take over, is it's not just about the piece of software, because a piece of software is just a piece of software. The key thing about what we're trying to do here is about collaboration and working together and reducing the amount of work we have to do and collaborate in that piece of software. But the EDGE program itself is also a knowledge base where people share experience and ideas. So our EDGE community come together both online and at annual meetings, both in the UK but internationally, and they do things like share standard operating procedures. They share individual trial ontologies, or practices, or protocols, or all sorts of other bits and pieces. So they're constantly sharing that knowledge around, rather than trying to reinvent the wheel individually. So it's not just about that piece of software, as I said, it's about joining a community of people to share experience. And of course, working collaboratively means we tend to be working slightly smarter. So I didn't want to go on for too long, but hopefully it just gives you an idea that this is something that's come out of an academic and a hospital environment. It's been designed by people like you in defining what it does, how it works, what they want it to do. And it's, like I said, it's a network of people, not just a piece of software. So you're joining a club in terms of being able to draw on all that expertise and experience as well. So I'm going to leave it there, unless anyone has any questions that they want to ask me.